Thank you so much. Yes, our thank you so much, Dr. Esther. And she forgot to tell you guys that she's even currently in Nigeria, and she's in my state, Edo State, right now, currently helping, to reopen the school that was closed for over 8 years. So this is great to NANNA. I want to thank Dr. Esther for doing that. She is from Ogun State, but she's in Nigeria now for 1 year in Edo State, 1 year. That is what it takes in NANNA. We go to each other's villages, we go to each other's states, to help support. And she has actually brought nursing visibility, or she has brought visibility to nursing in Edo State especially. So we want to thank God for her life, for her family's life, and for the great work she's doing. So yes, we've talked about health mission, conducting health mission, and the reason why NANNA changed from conducting what we call in those days health missions. That means going to people's village, check their blood pressure, give them medication, do it for 1 week or for 2 weeks, that like what Dr. Ruth said, and then we leave. But at the end, what happens? So what are the challenges of healthcare delivery in Nigeria? We know right now, according to the Federal Ministry of Health, Nigeria has one of the worst health indicators with 10% of global disease burden. And we all know that the increasing brain drain in Nigeria has resulted in shortages of nurses and doctors, and also faculties in the school. So considering the potential untapped considerations of migrant Nigerian nurses, the National Association NANNA developed a sustainable program to reverse flows of diaspora nurses for national development through binational and collaborations. So what we have done, we've seen that there are challenges with the missions that we are doing. People go to Nigeria, you spend a lot of money, you buy ticket, you buy medication, you go there for 2 weeks, then after 2 weeks, what happened? You don't go back again until 3 years or for 1 year again before you go back. It's not sustainable. A medical mission has been seen for a long time as charitable. However, there are challenges with it, and it's also uncoordinated, and it's not cost effective, and it's also detrimental to the life of our people. Believe you or me, there are people, when you go to medical mission, you give them medication. They don't go back to the healthcare system or to the doctor for follow-up until you come back again, if you ever come back the next year, the following year. So by doing that, so they're not continuing their medication, so you can see that their blood pressure will rebound. So we don't want that. So when we look at all these problems that are there with medical missions, we decided to go back and revisit our processes and structure that we have in place. Because medical mission often treat rather than prevent diseases. During the short-term medical mission, health professionals often treat those illnesses, and then they forget the long-term care. And also, due to poor access, there are difficulties with our community to go back. And we also see where medical missions, once it's done, people are stranded. They don't know what to do, the follow-up. So based on that, we now look at what we can do to actually make our mission sustainable in Nigeria. And that is how we change from take us to your village, regular missions, to now adopt a primary health center. If you can look at some of the slides we have, you could see some primary health center, and I'm sure most of you are from those primary health centers in the villages. They are nothing to write home about. Yeah, the primary health centers that we have in Nigeria right now is no longer functioning. So we see that if we adopt this primary health center and we help revamp them, our missions will be more effective. Because when we go back home, we are working with those primary health centers. Instead of seeing 100 to 200 people for 2 weeks or 3 weeks, now there is a continuity, there is sustainability to the mission that we're doing. And this is why we are now moving from just medical mission to adopting primary health centers. So before I move on to tell you what NANNA has done with that, I just want to describe in a little time about the levels of healthcare delivery in Nigeria, so that some of us are conversant to what the system is. Because what we do, we just go to Nigeria, we want to conduct mission. We don't really understand the processes and structure in place, which NANNA don't want to be part of. There are 3 levels or 3 tiers of government in Nigeria, which we are all familiar with: the federal, the state, and the local government. And that is also reflective of the delivery healthcare system in Nigeria. At the federal level, you have the tertiary institutions, those teaching institutions that we know. For example, I'm from Edo State, we have the UBTH, University of Benin Teaching Hospital. That is for the federal. And so when you're talking about federal, supposedly, if it's effective, there's supposed to be research going on over there, and it's supposed to be a big deal with tertiary hospitals. Then the state, at the state level, they have the secondary hospitals, which are known as the general hospitals. So I'm sure you've seen those are owned by the state government, run by the state government, the general hospitals. And then the local government is supposed to be responsible to the primary, all those primary health centers. The primary health centers. So in the next slide, you're actually going to see, how this works. And then you also have the private facilities. There are private facilities. So the levels of healthcare delivery in Nigeria is a reflective of the tiers of government we have: federal, state, local government. So the local government is responsible for those primary health centers who's supposed to reflect a primary healthcare system, which is a preventive medicine, that you have to do. So the World Health System ensuring functional PSC. In those primary health centers, we have over 10,000 population per patient ward. So what they did is that there are about 30,000 primary health facilities in Nigeria, 30,000. So we have all these health centers, but guess what? Out of the 30,000 primary health centers, only 80% of the primary health center, only 80% of the primary health center are not functional. Only 20% are functional, minimum functional. So you can see that you have all these buildings all over in our primary health center. So for those of you who visit Nigeria often, I would recommend you go to your village. There is a primary health center in your village. If you look at this slide, you can see that each primary health center there that is situated in the ward. Then you now have a general hospital, one general hospital per local government, which is run by the state. And then you have those bunch of primary health centers per ward, which is supposed to be very close to the people, so they can go there. But unfortunately, these primary health centers are not functional. Only 20%. So you have 80% that are not functional. So what NANNA have decided to do is to adopt these primary health centers and make them functional for our people. So when we do health missions, we will be focusing on the primary health center. So when you look at the primary health center, they are composed of the board, they have the chairman, they have representative, and they have workers there. But these workers don't go to work. This is what we found out. So because of time, I won't go too much into it, but I will just explain to you how the primary health center function. Each primary health center is supposed to have the World Development Health Center Committee. And those are the ones that are responsible for that health center. So what NANNA has done is to adopt those primary, where we've been conducting health missions, adopt those primary health centers. So once we adopt the primary health center, we make it functional, we make it livable, and so that our people, it becomes an asset to the community that is there. And that is why we've done so much with the primary health center. And I'm going to have Dr. Esther to continue with the challenges and opportunities, that we have using the structure and processes that is in place with this tiers level of government in Nigeria, especially the primary health center. What is our next step? We've adopted these 4 as a sample, as a module. We've actually created this module that even the United Nations have approached us to see how we're able to do it. So now we want to build on this module that we've done, is to adopt more primary health care, collaborate with Education and Research Committee. So when it comes to adopting more, we are now encouraging every member of NANNA to look at the primary health center in your ward or in your local government, and see what you can do. Even spending $1,000 a year, if you do that a year, in 5 years, that primary health center will be transformed, to a new one, and then we'll be able to serve more local people than just doing a regular medical mission. So our next step is to now create a criteria to adopt more. What we did was the 4, and the question people always ask is that how do you come up with a criteria to adopt those 4? What we did is that we've been going on missions, for the past 10 years. We've been doing a lot of medical missions to Nigeria. So those are the first leaders that have been participating in medical mission, and that they've been doing medical mission. So NANNA has actually carried out medical mission to Enugu, to Abia, to Imo, to Ogun, to Edo, to Abuja, to Lagos. So we conduct a lot of medical mission in these states. But we have people who stand out year in and year out. They be doing Take Me to Your Village. I think we also went to Ekiti State. So those villages that we'll be working with, that was the criteria we used, was to continue. Instead of doing the mission, NANNA used to give $2,000 for medications, for mission to these villages. So we now said, well, let's put those money that we're spending to those villages that we'll be going to. So that was the criteria that we used. So we now came up to adopt more. We came up with now a criteria to adopt more. The first is the primary care must be an existing part of the local government primary health center. Like I pointed out before, you have over 30,000 primary health centers. So we do not encourage you to build a new one, to start a new one, but you have to look at what is the primary health care that is there in that local government. The primary health care must have staff allocated to it by the government. NANNA do not hire staff, or fire staff. There are staff that are actually on the government payroll, believe you me. They are getting money, they're getting paid every month, and then they don't do the work. So that primary health center must have staff that are working there. And any individual must have a commitment from the community. Like Dr. Esther has said, without collaboration with the community, you won't do it. With Abia State, the community were building blocks, they were bringing water, to the people. So you need that community. So you have to have an MOU with the local government council, because the local government council is in charge of the primary health care. So you have to have their buy-in. You also have to have a buy-in from the king, which is the Enoge or Enige, who is the person, the king of that community. Then the community development committee, you have to have a letter of commitment from them. Then the primary health center medical director, and also the nurse in charge of the primary health center. Believe you me, all the primary health center have a matron or a nurse in charge of it. So you have to have their buy-in. You also have to have a commitment from a member that is adopting the primary health center. You can't just wake up one day and say you're going to adopt your primary health center without even knowing what is going on. There has to be an invested interest for like 2 years, and you should be able to document that you'll be going home, the community, the primary health center. You have to do a complete need assessment, like we said before. And then there is a proposal that these 4 coordinators for this primary health center did. So you have to complete NANNA Adopt Primary Health Center Initiative Proposal, and then submit a presentation by the community and the primary health center. So when you put all this together and the mission committee review that, then we'll be able to know those people how to support the next health center that we're going to adopt. To me, I will encourage every member of this forum to start thinking about it. When you adopt it, you could put your name in collaboration with NANNA For example, if Miss Beatrice adopt the one in a health center, you could put there, Miss Beatrice, in collaboration with NANNA, adopt this primary health center. Think about it as you leave this forum. It should be one of your takeaway. The proposal should be submitted. You should have a summary, just the way you do proposal. There has to be executive summary. You have to write about the local government. You have to have a background and needs assessment, and then project description, the project timeline. You don't want a project that is ongoing. You have to have a project timeline, and you have a budget timeline, and then you have a budget. And when you submit all this, we will be able to help you with logistics and then see where you are, with it. Please, I don't want you to take away from here that, NANNA is going to give us money to go build a primary health center. We are not building a new primary health center. Abia did it. Abia did build theirs from the ground, but that primary health center was part of the local government, the government health center already. And I just want to give a shout out to Minnesota. If you're on this forum, Minnesota really did a good job soliciting for money for Abia project. So that is the way forward for us in NANNA. We want more. Too many primary health centers, 30,000. If NANNA could do all the 30,000, that would be great. And that would really help the community. They will have a place to go. They will have a place to call their own. The mortality, maternal death that is happening right now will be reduced, if we do that. Diabetes rate will be reduced. What we put in place with the education for the primary health center, now each primary health center will have education day for diabetes, education day for high blood pressure. So we're actually transforming this primary health center. The module is unique, is excellent, and we hope to have more. Thank you.
How do you select the PHC that you adopt in Nigeria? And how do you determine? That's the first question. Dr. Grace, are you there?
Yeah, the way we adopted, I talked about it that in the presentation, as since NANNA has been doing missions for years, those communities that we visited, that we'll be going to, that our members have taken us to their village, we started with those 4. And so we use it, we tried it out, and now since 2019 to 2021, we see that it works. And then so we're going to continue with that format, so that those villages that we've been to, those villages that we'll be helping, then we will continue with those. Then those individuals that want to do their own, they can also come and we support them. But we have to continue with those villages. Those are the criteria. If we've never been to that village before, we can't just start with that village. It takes time to build collaboration. It takes time to build trust. It takes time to empower the community. So it's not going to wake up one day and say, oh my God, I want my village today. No, it's a journey and it's a process. In NANNA, we don't rush. We take time to assess, because if you have wrong assessment, you provide wrong intervention. So you take time. If you fail to plan, you plan to fail. So in NANNA, one of the things we do very well is planning and looking at structures and processes, and then we now embark on intervention. Thank you.
How do we improve the licensing process so that people can find it easy to renew their licenses? Unmute yourself.
Dr. Grace, is Dr. Mbibi on the line? Because she's the one leading us with this licensing thing. Dr. Grace, would you like Dr. Mbibi to address that?
She's in Nigeria right now. I don't know if she's if they're able to find her. If not, we have collaboration with Nursing and Midwifery Council. And we've said this over and over again. Dr. Mbibi has posted it on the forum, on the National Working Committee forum. So the chapter leaders have to take it to their chapter. So all you need to do is go with the person who is in charge of licensing for NANNA, and his daughter Ngozi Mbibi. She's in charge of licensing, renewal. So any question you have, any problem you have, just meet with Dr. Ngozi Mbibi. She is NANNA representative for licensure in Nigeria. Thank you.
What happens if the primary health center is full but not on optimal level? What can we do? It says,
yeah, that is what what the program is all about. Remember now that every primary health center is not at the same level. Like what Ms. Esther said, the one in Ogun State has a structure, the one in Edo State has the structure, but what they needed was a little renovation. The one in Abia State, the building was down, so they have to start a new building entirely. So it depends on the assessment. That is why a need assessment is very critical. Not all primary health centers are at the same level when it comes to deterioration. So you have to do your need assessment. Based on that, the needs assessment will give you the plan for intervention.